Hello everybody, back to my YouTube channel, and today we'll discuss a very interesting topic, that is secondary HLH and the evolving concept related to it. We'll start with a case, a 40-year-old gentleman, known diabetic and hypertensive, or medical management. He was diagnosed with acute myeloid leukemia and received induction chemotherapy for his treatment. On day 7, he was admitted to the hospital with a neutropenic fever, which is a very not an uncommon presentation. After chemotherapy, he received some empirical antibiotic as per hospital protocol. No definitive organ failure was there on admission, so they decided to manage the patient in the ward. But patient was having persistent fever, he was not settling down, so antibiotic has been escalated as per hospital protocol. Standard investigation was sent, and most of them was negative, except there was a mild transaminitis in LFT. And the procalcitonin was also low on admission. So eventually, the patient was shifted to ICU because of new development of hypotension. During his initial ICU course, the blood culture shows gram-negative bacteria, so the antibiotic was optimized. It could have been because of the PIC line, which was there since the day of chemotherapy, so the PIC line has been removed. It can also be due to primary bacteremia that we need to be aware that in patients with acute leukemia post chemotherapy because of extensive mucositis, there is a damage to the gut mucosa, and there can be bacterial transmigration leading to infection. So the patient was symptomatically doing better after the antibiotics and removal of the PIC of vasopressors, but his fever persists. And also the WBC was not recovering, so also his platelet count. So because of this pancytopenia and fever, we are not sure what we are dealing with. We have already given empirical antibiotics, and the repeat procalcitonin was also showing negative value. One option is fungal infection. We optimize our antifungal. Though the procalcitonin was negative, we escalated our antibiotic empirically. But we try to explore other causes of persistent fever and bicytopenia in this clinical context. So here, this patient is a post-infection in a hemato-oncological setting, persistent fever, bicytopenia. We could not identify any definite organ as a source of sepsis. Septic workup sent in the second time after the initial culture was negative. We rule out an endocarditis and other causes of inadequate source control. And this patient have a persistently low procalcitonin. In this background, we should consider other non-infective etiologies. And here, our provisional diagnosis was hemophagocytic lympho-histiocytosis. Though it is not that common in clinical practice, but hemato-oncological setup, it is we get patients occasionally, and also in general medical surgical ICU, because we do not think about this entity. A lot of time we miss it, and we eventually found that patient responded with some kind of steroid. So HLH is a life-threatening syndrome of excess immune activation. It can affect all age groups. It can be familial disorder called primary HLH, or can be a sporadic or secondary HLH where it is triggered by acute insults that disrupt immune homeostasis. If you look at the pathophysiology of the disease, it's a syndrome of excess inflammation and tissue destruction, as I mentioned, due to abnormal immune activation and excess inflammation. There is lack of normal downregulation of activated macrophage and lymphocyte. What happened in normal infection or inflammatory setup? Once the initial inflammatory cascade has been activated, there is a parallel cascade which start to control the inflammation, and there is a downregulation of activated macrophage and lymphocyte by natural killer cell and cytotoxic lymphocytes. Here in that case, these two cells fails to eliminate activated macrophage, leading to dysregulated hyperimmune cytokine storm-like state. There are different subsets of CD lymphocytes are involved, like CD3, CD4, CD8. There is an alteration in the CD4 CD8 ratio. There is an activation of the perforin-dependent cytotoxic pathway and toll-like receptors. There are different other cytokines and chemokines are involved, like interferon gamma, TNF alpha, interleukin 6, 10, 12, interleukin 6, 18, and soluble interleukin 2 receptor, also called CD25. Now, if I try to categorize the pathophysiological changes that happens, there are three steps. One is in the category 1, there is a predisposing immunodeficiency, which is can be documented by low or absent NK cell function, genetic defect in the cytotoxicity. This type of situation present in a familial history of HLH, as I mentioned. There can be prior episodes of HLH or unexplained cytopenias. There can be marked or impaired cytotoxicity that can be documented by decreased expression of perforin, SAP, and other molecules. In the category 2, there is a significant immune activation documented by persistent fever, splenomegaly along with hepatomegaly, elevated ferritin. We usually take 3000 nanogram per ml as a cutoff. There can be elevated soluble CD25 and soluble CD163 molecule. And the last part, the category 3, there is an abnormal immunopathology, which can be documented by cytopenias, decreased fibrinogen and increased triglyceride, hemophagocytosis, hepatitis, and CNS involvement. Now, in familial HLH, most of them usually present at a young age. There is a mutation at the FLH loci, like perforin, uni13, or syntax 11. There are associated congenital immune deficiency syndromes like Griscelli syndrome, Czerny-Gasi syndrome, X-linked lymphoproliferative disease, or X-Men syndrome. And it is must that there should not be any evidence of malignancy to stamp it as a familial HLH. The table has shown the list of genes that are involved associated with the mutation of the location. But what is more common for intensivist perspective in our clinical practice is secondary HLH. As I discussed, it was triggered by viral infection or worsening in the immunodeficiency state. It can be activated by autoimmune disease, malignancy like lymphoma, HIV, and sepsis. Viral infection has a very strong association with HLH, and most common virus that is involved is EBV, or Epstein-Barr virus. It is one of the most common trigger both in patient with a genetic predisposition, like in patient who has a genetic preponderance, as I discussed, or even in a sporadic case, like in immune activation type. There are other viruses also, those have been documented, like CMV, HSV, HHV6, and parvovirus. Patients with a familial disease or X-linked lymphoproliferative disorders are particularly at high risk. This can happen during acute infection, both in B cell or T cell and NK cell subset of patients, and the survival improves with early initiation of etoposide containing therapy. And there is a strong association of HLH with malignancy also, especially hemato-oncological malignancy. It has been reported primarily with lymphomas and leukemia, FT and NK cell lineage. There is an associated with anaplastic large cell lymphoma, early B lineage lymphoblastic leukemia, myeloid leukemia, mediastinal germ cell tumor, and rarely with other solid tumors. Why T cell and NK cells? Because as I discussed, these are the two cell lineage which controls or stop excessive immune activation and suppress those overactivated lymphocyte and macrophage and neutrophils. Here, the context usually stimulated by a bacterial, viral, or fungal infection that serve as a trigger. Another similar entity called macrophage activation syndrome, which has been associated with rheumatological disease. This is a change in terminology and some change in the presentation. It was initially reported in systemic onset juvenile idiopathic arthritis and also reported in lupus. Patient usually present with fever, hepatosplenomegaly, hepatitis, like features, lymphadenopathy, and DIC. And the cytopenias are usually a late finding contrary to hematological malignancies. Patient with hematological malignancy. Hemophagocytosis can be documented in bone marrow and other tissue. There are associated depressed NK cell function, depressed expression of perforin, elevated soluble CD25 and soluble CD163, and there is polymorphism or heterogeneous mutation of PRF1 or UNC13T. There is also a very interesting finding called comparison of gene microarray. There is a unique early erythroid signature because of consumption leading to consumptive anemia. How to diagnose? As I mentioned, this is not a very common disease. So, whenever we are getting patients with fever and bicytopenia and without any definitive source of sepsis, this should be is one of our DD. Associated clinical features, rest of the clinical features are very non-specific, like fever, splenomegaly, which is very common, present in more than 90% cases, hepatomegaly, lymphadenopathy, neurological features, and rash. So to diagnose it, we should have a very high index of suspicion. Mostly the diagnosis got delayed because of rarity of the syndrome, variable clinical presentation, and lack of specificity in the clinical and laboratory finding, complexity and lack of specificity in the diagnostic criteria. We look at the clinical feature, hepatobiliary dysfunction is very, very common. So it doesn't come in some of the diagnostic criteria. We'll discuss it in detail later. Neurological finding can be because of encephalitis, seizure, ataxia, and praise, and they present with an altered sensorium. And eventually, there are multiple other systemic involvements like respiratory, cardiovascular, renal, and dermatological, and eventually leads to multi-organ failure with a high mortality and morbidity. For hepatic dysfunction, there is a strong association. This type patient usually have an unexplained liver dysfunction. It can vary from mild transaminitis to fulminant liver failure. GGT is most sensitive because of the biliary tract infiltration by the lymphocyte and the macrophages, and eventually that leads to hypertriglyceridemia and deranged coagulation in this subgroup of patients. In terms of the laboratory finding, bicytopenia, mostly anemia and thrombocytopenia is common, along with DLFT, suggestive of hepatitis, and also there is a abnormality in the coagulation parameters. They usually have a high ferritin. The median value is around 3000 nanogram per ml. A ferritin level more than 10,000 microgram per liter has a 90% sensitivity and 96% specificity for diagnosis of HLH. And there's a very minimum overlap with sepsis, infection, and liver failure. Those may also cause increase in ferritin. But these results are heterogeneous because studies have also shown that patient the probability of HLH in patient with a ferritin more than 50,000 is only 17%. So it is very difficult to get a definitive cutoff of ferritin to diagnose HLH. We have to look at the other findings also. So the diagnostic dilemma will continue because the immunological studies which can confirm HLH like elevated soluble interleukin 2 receptor alpha, reduced NK cell activity, or cell surface expression of CD107 alpha, elevated soluble CD163, reduced perforin SAP XIAP, or the altered function of the peripheral blood T cell subsets proved by a normal helper suppressor ratio with a low number of B cells and variable immunoglobulin test. This type of immunological profiling is done only in high-end research centers and cannot be used in regular practice. So routine diagnosis of this patient will remain a challenge. So if the diagnostic criteria laid down by HLH 2004 trial, this suggests either you can diagnose by molecular identification of HLH associated gene mutation as that has been described, or 5 of the following 8 findings that include fever more than 38.5 degrees centigrade, splenomegaly, peripheral blood bicytopenia, hypertriglyceridemia or hypofibrinogenemia, hemophagocytosis in bone marrow, spleen, lymph node, or liver, or also in peripheral blood, which is very difficult to demonstrate. Lower absent NK cell activity. Here the ferritin cutoff is more than 500 nanogram, but more than 3000 is more suggestive of HLH. And elevated soluble CD24, 25, which is also called soluble interleukin 2 receptor alpha, more than 2 standard deviation as per the age adjusted value. But this does not solve our problem because 3 criteria, that is hemophagocytosis in bone marrow, spleen, lymph node, absent NK cell activity, and elevated soluble CD25 are very difficult to perform. And I have been already discussed the reason. On the other hand, bicytopenia, splenomegaly, fever, and high ferritin are very, very common presentation in patients with hematological malignancy and sepsis. And at the end, the other suggestive clinical findings, as I discussed, are very, very common in HLH, like CNS symptoms, hypotension, renal and respiratory insufficiency, are not included in the diagnostic criteria. So the present modified diagnostic criteria laid down has been followed, like 3 or 4 of the clinical finding like fever, splenomegaly, cytopenia, and hepatitis, plus 1 of the 4 immune markers, hemophagocytosis, high ferritin, hypofibrinogenemia, or absent or decreased NK cell function. If we can show this, this is probably an HLH, very strong association. If I want to confirm it further, there is a detailed coding system called H score, where H score is more than 250, the chance of probability of HLH is very, very high, more than 99%. And with the H score less than 90, the probability is very, very minimum or negligible. Now, for the treatment, as I already discussed, early diagnosis is very, very important because they have a very poor outcome if we not able to diagnose in the initial phase. You have to go with an induction therapy to suppress the life-threatening inflammatory process that underlies HLH by destruction of the immune cells. So treatment of the triggering condition is also very, very important and have to be started simultaneously. They usually need 8 weeks of induction therapy with the dexamethasone, etoposide, and intrathecal methotrexate. Cyclosporin early in the induction, along with hydrocortisone, is important, specifically if there is a CNS involvement, along with intrathecal methotrexate. After 8 weeks of therapy, induction therapy, we should wean off immunosuppressive therapy, or if the patient does not respond or patient need a continuation of therapy, so probably we have to consider for transplant in coming time. And patients who have a HLA gene mutation, central nervous system involvement, or disease relapse after the induction therapy usually require a hematopoietic stem cell transplant. As I mentioned, we need to treat the trigger also. For sepsis, we have to treat the infection. For hematological malignancy, once you start HLA specific therapy, you have to consider for appropriate chemotherapy for the malignancy. And sometimes eventually it leads to hematopoietic stem cell transplants. If the patient has an active EBV infection, that is more than 10,000 copy of EBV per microgram of cellular DNA, then the treatment is rituximab, weekly dose for 1 to 4 weeks, depending on how quickly the EBV level is coming down. If we are not able to give rituximab for some reason, we have to consider for IVIG. Now, the clinical protocol, the intensity of the clinical protocol, treatment protocol depends on the stability of the patient, how sick the patient is. If the patient is clinically stable, sometimes we just need to treat the triggering condition, that is sepsis, maybe some amount of steroid. If the patient is acutely ill or deteriorating, that is the deteriorating in terms of organ function like cardiovascular, pulmonary, renal, hepatic, or neurological, then you have to give more intense HLA treatment, as I discussed already. And the treatment will vary depending on the laboratory value. That is what is the amount of the liver dysfunction, renal dysfunction, and all those things. If the patient has a significant hepatic dysfunction, alantuzumab will be an alternative to etoposide. We should consider to use it. Follow up. Yes, we need to follow up along with clinical response. We can do some disease specific marker like ferritin, soluble CD25 and 163, NK cell function, and the viral titer for EBV. And if the patient has a relapse or clinical failure, there is a high probability that they will require a transplant. So to conclude, HLH is a rare disease, but because it is a life-threatening condition, we need to have a very high index of suspicion and appropriate context. Specifically, the patient has an unexplained fever without any definite source of sepsis, bicytopenia, and with a high ferritin. We have to address that figure. If it is sepsis, we have to give the antibiotics, viral infection, treat the viral infection if possible. Hematological malignancy, treat the malignancy after starting the HLH therapy. Early treatment is very, very important because the drugs are not that regularly used in intensive care. Better to involve a hemato-oncologist or rheumatologist, depending on the clinical context. And even after all those things, the outcome may not be very satisfactory. So early diagnosis and strong index of suspicion is the key. By this, I'd like to conclude my presentation. Thank you.